So we were talking about our pasts. When did you start your surgical residency?
1987.
87, and that was where?
At Albert Einstein Medical Center in Philadelphia, at the Knife and Gun Club.
Right, so I was 84 in New Orleans, and thinking of what breast cancer looked like back then, most common operation, modified radical mastectomy. If you mentioned breast conservation,
it was heresy.
It was heresy. And one surgeon was doing radical mastectomies and didn't believe in the bovie and was tying perforators with cotton ties, believe it or not. We had to put patients on boll weevil precautions post-operatively because there was so much cotton that was left in the wound. So thinking about where, you started where?
1983 in University of Louisville. And I was just thinking about, I remember a day in 1985, I'm pretty sure, when the NSABP B06 trial came out, and the way we knew it came out because it was headlines. Mastectomy is not needed. We had 3 mastectomies scheduled that day. We canceled all 3 of them.
Wow. That was big news in Pennsylvania because Bernie Fisher, right down, huge. Pittsburgh was like the mecca of change. And in Philadelphia, it was Bobby Summers and Gordon Schwartz who were the ones that just, the next day it was like breast conserving surgery for everybody. And it was kind of like my residency went from, okay, then what are we gonna do? What are we gonna do with all of these women? Because changing how we're thinking about everything, and this is when people were still coming in the day before surgery, getting checked in the day before surgery, think about it. Come in the day before surgery, spend the night, do your surgery that day, and then be in the hospital for a day or two after lumpectomy and axillary node dissection, because we didn't even know what a sentinel node was then except for potentially melanoma.
Judy, you started when? You started?
1999.
99. And where did you do your?
South Carolina.
South Carolina. So you came into this business at a very different point in time.
Definitely. When I was in residency was the time where one of my consultants was just kind of proctoring and learning sentinel node surgery, and was still doing sentinel node with backup axillary dissection to look at her own personal false negative rate. So that was my introduction to breast surgery. But yes, we were definitely doing lumpectomy.
My B06 memory is not the day that they unblinded it, but the day they found the falsification from Dr. Poisson, and I got a phone call. Can you be interviewed on national news tonight about the falsification of the data in the B06?
Not the way you want to make your debut on.
Yeah. Not, but the funny thing is they came. I lived in Pelham, New York, a little suburb north of New York City, and it was a winter day, and I had a big roaring fire. So they put me in a chair next to the fire to talk about what this meant. But at the bottom it said, Dr. Borgen in his office in Manhattan, and there's a roaring fire going. So my colleagues are calling, going, "Dude, you have a cool office."
That's hysterical.
But that was a dark moment, and Dr. Fisher just paid such a terrible, unthinkable price for that whole.
And Norman Woolmark still loves to tell the story of almost going to prison, and getting subpoenaed, et cetera, et cetera.
Well, you think about that was such a pivotal moment for breast cancer surgery, and then to have that much of a dark, deep-rooted badness associated with it. I mean, it could have turned around the whole face of what we do in cancer care now.
Yeah. So for people that don't know the whole history, what happened after that? How did they then reanalyze the data without his patients, or how did you recover from that?
The NSABP found out about the falsification. Remember that accrual bought authorships, and authorships bought grant money. And so there was one center in Canada that was accruing largely deceased patients to the trial. And their records in French were marked true and false. And so an audit blew the lid off this. They reanalyzed all of the data, and they had carefully balanced the falsification so that it would not impact the outcome. And Dr. Fisher made a very conscious decision to not call attention to it because he was afraid it would drive women to unnecessary mastectomies. The Chicago Sun, some newspaper, maybe it was the Sentinel, blew the lid off the story. And a congressman, Dengel, from Michigan, launched a personal attack on Dr. Fisher for sort of misappropriation of tax dollars in the clinical trial arena. On every publication, they stamped under fraud investigation. He was hounded. He had to. There was concern about going to jail. Mm-hmm. What did Dr. Womark tell you about that?
He got a summons because of mail fraud, so a federal offense because it went across state lines. And I don't think they actually hauled him into, the jail, but he had to get attorneys and probably a bad year. In the end, the other kind of interesting thing about NSABP B06, it changed what we do. We all agree it was a just perfect change to de-escalate what we were doing to everybody. But the interesting thing about it is that we could never do it now. It was a failing trial. Nobody was being accrued to it. And so somebody invented pre-randomization. So before they would approach the patient, they would randomize her and they would say, good news, you're a candidate for the trial and you would get mastectomy, which we think is standard and it's what you would get anyway. Or good news, you're a candidate for the trial and you would get lumpectomy, which is a great new treatment we're studying. And so it started accruing.
Everybody
whereas
thought they were
it
going
was,
to get
they
the very
knew
best
what they
thing
were
for
going to
them,
get,
yeah.
yes. And so now that's considered completely unethical and it would never be conducted now and we'd probably still be doing mastectomy.
Right. Wow. And with NSABP, who I actually adore, you couldn't look at the conclusions in the paper. You had to look at the design of the next trial. So remember that in B06, the lumpectomy group without radiation had a 40% local recurrence rate. And of course, it was underpowered to show a survival disadvantage associated with that local recurrence. But in the paper, they talked about the fact that there was no survival disadvantage, but every subsequent trial included radiation therapy. So with that group, you always looked at the design of the next trial. So interesting days.
What I have to share with these guys is your slide. I call it my Patrick Borgen slide, because in 1995, I think it was, I went to Memorial Sloan Kettering because you were doing this new procedure called sentinel node mapping, and in your talk you had it's a slide that goes from the 1980s. Now it goes up to 2022 because I've now added on to it. But it was like showing the progression of what we were doing with blocks of therapeutic interventions. And it was really cool because I was out in private practice for like 3 years then. And when I was bringing this into my hospital, they're like, well, everybody gets axillary node dissections. I said, no, they don't. You can do sentinel node, but it was, as a solitary surgeon doing this, I had to come up with, and I think I used one of the protocols that you had suggested, that for your first 20 cases doing sentinel node, you identify the sentinel node, you complete the axillary node dissection to make sure that you're doing it. I think it was, and my hospital said, well, as an institution, we need to do 20. And so I did 20 of them, but the other surgeons had done none. I said, well, you guys can't just tag on because now we've done 20 at our institution. But I remember at the time when I had patients who, I really wanted them to have a sentinel node because I knew they could do it. I would send them down the street to Fox Chase, which had already done their cases, because I thought it was really unfair to these women knowing that they could go to another surgeon right then and there. So I would disclose to the patients, listen, axillary node dissection has been standard of care. We are now instituting sentinel node biopsy, which sounds probably foreign to you now with this, but I said, I can do your surgery, but I have to take your sentinel node out and then complete your axillary node dissection, And I was amazed at the number of patients that actually stayed there to do it, because at the time they didn't have the internet to be connecting all of the lymphedema, the risks, all the stuff. But that's how we started doing new procedures. And so that was in 1995 or 96 with you. And then I'll never forget, 2002, I was teaching a breast ultrasound course, and I look out, and he's in my audience, and I'm teaching him breast ultrasound, and I'm like, Patrick said, wow, I kind of left. I'm going out to Maimonides, and I need to know how to do ultrasound. It was kind of cool because it just made you recognize that we're in a great specialty where we all have a great skill set, and sometimes you're the leader, sometimes you're the student, sometimes you're the follower. But we tend to take care of our own, That's what today was all about. Sitting in this room with all these great minds saying, like, how do we make our profession be one that we're going to be proud of 15, 20 years from now? And are we meeting the needs of our patients? Are we giving our patients what they need? Are we giving our fellows, when we train them, what they need? And that's been my favorite thing about these 3 days is it's way more than I expected. I wasn't expecting to have some of the conversations that we had.
Yeah. Well, let me just say that I'm really flattered that you remember a slide that I made 30 years ago. But it is still my favorite slide. And what it was the ideal treatment of breast cancer. And anything that graphed above the line was unnecessary overtreatment, and below was dangerous undertreatment. And I actually started in 1890 with William Halsted as sort of the starting point. And by the way, Wild Bill Halsted is buried half a mile from my hospital in Brooklyn, New York, in Greenwood Cemetery. So whenever y'all come visit, I'll take you to Dr. Halsted's. So then we went from Halsted for half a century to Wangenstein and Jerome Urban's extended radical mastectomy, and down to radiation alone, to modified radical. And what I'm proud of about what we've done is an unselfish de-escalation. This has not been true across all other specialties in breast. The surgeons have pivoted time and time and time again because it was the right thing to do for our patients. And I'm really proud of our specialty for even today, we're looking at who doesn't need surgery at all, right? And in an exceptional responder group. And if it's best for our patients, we're going to embrace it. But we haven't seen the same de-escalation across all areas of breast oncology. We haven't.
But we did, probably Judy did not, but many of us grew up with this very Halstedian notion of the cancer is here, and now it's here, and now it's here, and we just need to get outside it, and the patient's going to be fine. And so when you were doing an axillary dissection, getting that last node up there was probably going to save the patient's life. You really believe that.
I remember locker room conversations. How many nodes you get? I got 31. I got 32. I got 41. And really there was a certain sense, and this is the early 90s, late 80s, where the more the better. You did a better operation by taking out 52 negative lymph nodes. And that was the Halstedian centripetal spread model that Bernie Fisher, thankfully, took a shot at, successfully.
How many other surgical subspecialties think about it? I don't know, between colorectal, ENT, other areas of subspecialty, breast surgeons have the ability to impact every piece of their patient's care because we weigh in on genomics for tumors. We weigh in on genomics for chemo and radiation. We weigh in on genetic testing. Like, there's no piece of the patient's care. Like, I always tell patients that breast surgeons are the captain of the ship. And that's the piece of this process, I think, that has been very special that we've maintained as the surgeons, is the ability to recognize that we can read all the papers they read. You slice and dice data like nobody I've ever seen when you're doing a presentation. So I don't care what argument it is, whether you believe it or not, you're going to be able to look at the data and present it in a way that you can make this convincing argument. And doing that for your patients, each one of us, we're being advocates for what we believe in our heart to be the very best care for our patients. And the fact that now a lot of the genomic and genetic information that's coming out, it's changing our surgical practice so that we're doing less invasive things. We're doing less RVUs. We're doing, we all do now nipple-sparing mastectomies, which, I remember our conversation at the ASBS about, well, we work twice as hard, it takes us twice as long, and we get paid less than, and so for a surgeon who isn't focused on the care of our breast patients, like many of the surgeons in the country doing it, what is their carrot to get them to take the time to learn the techniques, to do the stuff? And that's still the sad part about breast surgery, is that if someone doesn't go to a surgeon who has a focus and a passion for care of breast cancer patients, they may not get that level of care that they need.
Yeah, they may get it, but they may not. And that whole business of being focused and staying up with what's going on has made pretty much a big difference in at least a subpopulation of patients that would not have turned out as well.
So I really agree with what you're talking about, and part of what's unique about the Miami Breast Conference that I run is that the surgeons are in the audience for the immunology, the radiation, the genetics, the genomics, the proteomics. Both Pat and Judy have been on our faculty. Pat's played a seriously important role. We got to get you down there to join
I'm
us. And what you were saying earlier about, Judy's ability to really dig deep into this data is like nothing I've ever seen. So I really appreciate that, your contributions. And Pat never stops thinking outside of the box. And Pat brings a very special aspect to Miami, which I'm very grateful for. But what I really love is that audience with the surgeons who want to be the captain of the ship or the quarterback of the team, who really want to understand PD-1, PD-L1 inhibitors, because when their patient asks, gee, I have a triple negative 3 centimeter breast cancer, and you can say, well, let me explain Keynote 522 to you, that's what you have to be to maintain that role as captain of the ship. So
I think that's one of the interesting things. When I went into breast fellowship, I knew very little about breast surgery, right? And I thought, I'm going to do this fellowship and I'm going to come out knowing everything I need to know. And I finished the fellowship. I learned a lot. I had some wonderful mentors, but I think I had more questions at the end of the year than I did at the beginning of the year. And then even now, when you look on several decades later, it's like the education just continues, right? I mean, the procedures that we are doing are not procedures that we train to do. So you have to kind of stay up with what's coming, what are the new techniques, what are the new technologies, which are the right patients to consider that. Then you get into kind of the dilemma you were in of like, how do I tell the patient this is the first time I've ever done a nipple-sparing mastectomy, this is the first time I've done a sentinel node biopsy, this is the first time I've done a seed-localized node excision, those kinds of things. But all of us are doing procedures now that we weren't doing 5 to 10 years ago.
So thinking back to meetings that you've been at, what is something that you heard, and at the time you said, that's crazy, and then 2 years later it was standard or you embraced it?
Well, I wouldn't say standard, but robotic nipple sparing for me is the one that I'm really kind of watching this space on, because there's a certain degree where it's like, it's breast surgery, you've got to get the whole breast out. I can't imagine doing this robotically. You can't get the breast out of a 3 centimeter incision, so what are we fighting here?
So do you think it's got a future or not have a future?
Well, we're part of the robotic nipple sparing trial. I don't have robotic skills, so I'm the bedside surgeon. My junior partner's on the robot. She's phenomenal. And it's really changed my outlook on it, because the visualization you get of those planes is like nothing that you get open. You would never have
Can I come
imagined
for a
it.
site visit?
Just come out.
Because it's one of the things that I'm like, why are we doing this? Like, what's going to be the benefit of doing a robotic nipple sparing mastectomy? And my junior partner, Dr. Kreischer, back on the East Coast, she's looking at this, and I'm thinking, Stacy. She goes, but Stacy was a hugely talented laparoscopic hernia colon surgeon. I mean, like, her laparoscopic skills are crazy. And she went into breast because she ended up loving the breast cancer patients and the multidimensional things we got to do. So I know that she probably misses that technical piece of it. And because she asked me about it, and I'm like, I don't know enough about them to judge, but it's certainly like, if you come out after this trial and say, listen, kids, we got to pay attention to this because this is something, people are going to believe it. If you come out and say, you know what, it's kind of cool, but it doesn't work, people are going to believe it. So be careful what you say.
Well, let me say something here that people are beginning to talk about more at meetings, but people don't talk about enough. Surgeon ergonomics.
Oh, why do you think I have a pain patch on my back?
Right.
My L45 disc.
Who's got neck pain, back pain?
Yeah.
I'm like, if we're getting down to doing 2 bilateral nipple sparings a day, we're all going to be like this, right?
Yeah.
And you can't underestimate the impact of that just on availability of surgeons across the country,
so
right?
So I don't know who's credited with the first robotic mastectomy, but one of the first was a guy named Cattison, who's actually on my faculty. He's a Northwell surgeon. And they did it out at LIJ, and it was a many hour operation. There were a couple of skin things, and it worked. It absolutely worked. But I think I had the same reaction of, let's go through the advantages of this when we can do a pretty small incision with fiber optic retractors. And so I'm fascinated that you're part of this trial. And
Stay tuned.
I keep saying I wish there was a robotic indication with breast. Maybe.
And right now we're only doing it on patients for risk reduction. So the cancer aspect, I think, is going to be another whole.
You did
hurdle.
say what's something you thought was crazy, you know.
Well,
so
you opened the door, so I went there.
Yeah.
Listen, I hope it's not crazy. I hope it's good for patients, and I hope it's good for surgeons as well.
What's been interesting for me is back when I went to learn sentinel node from you, I was always kind of an early adopter of a lot of things, and when stereotactic biopsies, showed up on the horizon, I talked about, went to my radiology group at the hospital I was, and I said, we need to be doing these, and like, well, we don't want to do biopsies. And I said, well, let's go. So I went and got trained, at Steve Parker's, biopsys course. So I was the surgeon in the room with all the radiologists, and I came back, because at first I was like, yeah, I'll just biopsy the things on stereo that I can't take out with a needle look, because my mindset was, I'm a surgeon, I'm supposed to take it out. Then I started doing those biopsies, and it's like, why are we not doing these on everybody? And so I started doing stereotactic biopsies before most radiologists did. And then I, went to Miami Breast, thank you very much, and got my first ultrasound, bought my first ultrasound I think in like 2000 or 2001, whatever. So I've gone to Miami Breast ever since the 1980s when I was a general surgery resident. And that was where I kind of got clued into the fact that this is kind of cool surgery, and I liked it. And plus Miami wasn't bad in February, it was very good timing. Yeah. But doing the stereo certification and then putting an ultrasound probe in my hands. And I remember the first time I had an ultrasound in my office, I'm thinking, oh my God, what did I do before this? Because when I did my first Laszlo Tabar course in 1992, right after, I was like, I want to pull every mammogram that I've ever looked at, because clearly I've missed all these things. So I feel really, even though I didn't have a fellowship, like a 1-year fellowship, I had a 20-year, I just kept following the really good people. I followed Pat around, followed you around, just followed all these people on this path who were early adopters of new technology that was legitimate. I hated the Abbey. The minute I saw that, I go, this procedure makes no sense. Why would you drill? Do you even know what an Abbey is? You don't. It was this horrible, minimally invasive biopsy procedure. It took this giant trocar straight through the breast, like massive wombo, like whacked out. It was horrible.
This is different to your intact breast biopsy. Okay.
So, going through this process, I got lucky in surgical residency, because my first 3 years I did open gallbladders, and then I got to go. I was the first one from my residency to go with Eddie Joe Reddick and Bill Say, and I came back and did my first lap chole on one of my clinic patients, and of course she had an aberrant right hepatic artery, because you could never make that up, right? But I felt really fortunate, because I had 3 years of open gallbladder. So many residents now don't even know how to do an open gallbladder, because they do them all laparoscopically. Yeah. And so to be able to have kind of this, I did axillary node dissections all through residency into my private practice, and then added sentinel nodes. So it's like, I feel kind of spoiled that a lot of surgeons don't get that experience, because I think it made me better at adopting, like when I started doing nipple sparing, I started from the top down, and then I watched, Charlie Cox give one of his lectures, and he showed me how he took the breast off the pectoral muscle. I'm like, why didn't I think of that? It's because I was trained to take the breast off the skin. And so that's one of the things that's so amazing about breast surgery, is like, people aren't hiding their secrets. They're going like, here's my secrets. Here are my tips and tricks. Here are the things to make it easier. And that's something that's pretty special about our surgical group.